Good afternoon, everyone. First, I would like to acknowledge the traditional owners of the land on which I stand today, the Yagara and Turrbal people, and pay my respects to their elders, past, present, and emerging. Today, I'm presenting some results on endometriosis from my research team. In particular, work with Dr. Ingrid Rowlands and Dr. Katrina Moss, who will also be presenting next. If you have any questions, please type them into the chat window and I will do my best to answer them at the end of my talk. Endometriosis is a debilitating inflammatory disease occurring when the tissue that normally lines the uterus grows outside on other organs, typically around the pelvis. It has been associated with painful periods, heavy menstrual bleeding, bowel and bladder pain, and infertility. So this disease is a major public health issue that is not only highly disruptive to women's lives, but it is also estimated to cost the Australian economy more than $7 billion each year. Historically, endometriosis has been under-recognized by the medical profession and the broader community. A low level of understanding about the condition has contributed to diagnostic delays of up to 12 years. And part of this is because the symptoms that characterize endometriosis may be easily confused with other conditions. It is a highly individualized disease. Some women will be asymptomatic or experience few symptoms. Some will have symptoms that come and go, and others will have reoccurring symptoms that impact on a daily basis. This adds a layer of complexity for doctors, and often only those with expertise in the field may suspect endometriosis. The issue is also complicated by the fact that surgery is required to confirm diagnosis of the disease. Because this procedure is invasive and not without risk, some women and also their doctors may be unwilling to proceed with surgery. However, the National Action Plan for Endometriosis, announced in 2018 by Health Minister Greg Hunt, is a major policy initiative to change the way we manage the disease in Australia. The plan aims to improve the awareness, understanding, treatment of, and research on endometriosis. The plan sets out priorities for research, including the need to use longitudinal data from existing national data sources to provide a better understanding of endometriosis. The Australian Longitudinal Study on Women's Health was identified as a unique resource with the capabilities to advance knowledge in the field. As a first step, we needed to identify the extent of the disease in the population. It is estimated that more than 10% of women are living with endometriosis. However, this figure is based on international data. Reliable estimates for the prevalence and incidence of the disease in Australia were urgently needed to inform policy and practice. So first, a quick background on ALSWH for those of you who were not here yesterday. This is a national flagship study funded by the Department of Health since 1995 to help understand factors affecting women's health and well-being. The results we are discussing today are mainly from the cohort born in 1973-78, with some additional findings from the 1989-95 cohort that was recruited to the study in 2013. The samples are broadly representative of women in the Australian population at the time of recruitment. The 1973-78 cohort were aged 18 to 23 in 1996, and now they are in their 40s. A key strength of ALSWH is that we have detailed repeat data on the same women. So this means that we can follow women through key events. Women in this cohort were asked about endometriosis since survey 2 in 2000, when they were aged 22 to 27 years. Another advantage of the study is that we have record linkage with multiple administrative databases. Specifically relevant for this research are hospitalizations, MBS, and PBS data for health services use and prescriptions. Through sophisticated record linkage, we combined data from multiple sources, matching women's reports of a doctor diagnosis of endometriosis with their individual hospital and medication records. In the 1973-78 cohort, just over 1,600 women had the disease, with about 60% identified through hospital records, MBS or PBS data. So, by leveraging the longitudinal data available from ALSWH, we have estimated for the first time the prevalence and incidence of the disease among young Australian women. We found that 1 in 9 women in the 1973-78 cohort had received a diagnosis of endometriosis by their mid-40s. To put this in context, the prevalence rate is similar to or higher than other chronic diseases by this age, including asthma at 11%, diabetes at 4%, and heart disease at 4%. When the analysis was repeated for the 1989-95 cohort, we found the prevalence rates were consistently higher compared with the 1973-78 cohort at the same age. This may indicate an increase in the underlying condition, which would be concerning, or evidence of earlier diagnosis of endometriosis through greater awareness by women and health professionals, which would be some good news. We will need to see what happens going forward, though. The graph shows the incidence of diagnosed endometriosis over time in the 1973-78 cohort. The rate of new cases peaked for women in their early 30s. This coincides with the peak childbearing age of women in Australia. So the peak may be due to women seeking advice from healthcare professionals when they're trying to fall pregnant and thereby increasing their chances of receiving a diagnosis. This work is in collaboration with the ALSWH, which used ALSWH prevalence statistics in their 2019 Endometriosis in Australia report. Our contribution was funded by MRFF NEST network and was one of the first initiatives under the National Action Plan for Endometriosis. Now, I would like to discuss research that focuses on women's journey through endometriosis. ALSWH data over 8 surveys allow us to investigate some of the implications of the disease on women's lives. To illustrate here, we'll look at employment status and also at body mass index. So in this first example, we examined the changes in full-time employment. On the y-axis is the percentage of women in full-time work. We have survey data for before, at, and after diagnosis. These are represented by the different shades of purple. We have 3 groups of women. In the first, we have the clinically confirmed cases. These are women who were admitted to hospital for endometriosis or received a hospital discharge diagnosis for the disease, as recorded in the MBS or hospital data. In the second, we have the clinically suspected endometriosis. These are women who reported a doctor diagnosis of the disease in the ALSWH survey only, or who had only been prescribed a restricted medication for the disease, and this is based on the PBS data. The control group were women without endometriosis, who were matched by age. We saw a decline from 63% to 43% in women in full-time work after confirmed diagnosis. This is much larger than in other groups. This suggests that confirmed diagnosis is accompanied by a substantial socioeconomic impact for the women. In this example, we examined the association between body mass index and the diagnosis of endometriosis. While being underweight has previously been shown to be associated with the disease, our most recent work demonstrates that endometriosis might occur at both ends of the BMI spectrum. The graph on the left is for likelihood of a clinically confirmed endometriosis by 4 categories of BMI, while the one on the right is for clinically suspected cases. So compared with women in the normal BMI group, those who are underweight were more likely to receive a clinically confirmed diagnosis, whereas those in the overweight or obese categories were more likely to receive a clinically suspected diagnosis. This means that they may have been overlooked in diagnosis and in the research. We can only speculate about why this is, but going forward, less invasive methods of diagnosing endometriosis will be crucial to a faster, more equitable diagnosis and treatment, and will advance our understanding of the disease. So just before Katrina presents further findings, I would like to mention GALLIES, which is our new MRFF-funded project. This is the first major study to collect saliva samples for DNA analysis from ALSWH cohorts. So in the next 4 years, this project will produce new evidence on risk factors for the disease, an endometriosis risk calculator, and also there will be the co-development of new health advice resources. We've received positive feedback on GALLIES from the pilot study. Women have highlighted the issue of delayed diagnosis and that the research is important. So we're excited to be moving forward with this project, with the main survey already launched this month. At this point, I would like to wrap up. Thank you for listening, and I'm more than happy to take questions.
Okay, I hope everybody can hear me. Thank you very much for the questions. So I'll have a look at, all right, so we'll come to the question that I received the very beginning of the talk, and it's about, given that it is a hereditary disease, how much research is done on these generations with it? As I have a grandmother who had it, my mother, and now and daughter now. Spot on. It's been estimated that about 40 to 60% of the condition is hereditary. So you would have heard me saying about the GALLIES survey, and this is really where first time we're collecting saliva samples to be able to look at some of the known genetic variants and link it with the diagnosis of endometriosis. Professor Grant Montgomery at the University of Queensland, he's done a lot of work on endometriosis. He's contributed to the National Action Plans. So we'll be working very closely with him and collaborating with them. The other good thing is that for women who are visiting the hospitals, they are actually collecting the tissue samples of endometriosis to really understand that disease a lot better from the biological perspective. So I tell you, in the next 5 years, there'll be a lot of really useful high-level research to have come out of it as a result of the National Action Plan for Endometriosis. So that is one thing. The second, another question is that if gold standard is surgical diagnosis, how do the women accurately report having endometriosis? Well, for a lot of the women, it would be their symptoms. So women with endometriosis typically complains about chronic pelvic pain, heavy menstrual bleeding, and also painful periods. They could also have problems like bladder pain, bladder and bowel pains. So these are the symptoms that the women usually report. In terms of, having painful periods that really affect their quality of life, they're not able to go to school or to work, they'll see their doctors, and then the doctors will suspect that way. And it's repeated. I mean, from our survey, it's not only once that we looked at when they say that they've been diagnosed by their doctors that they have endometriosis. We repeatedly look at the medication that they're using, that they've been prescribed. So we try and narrow that down to accurately identify this group of women. The other thing is, why would diagnosis impact employment? Again, this is a very good question. It could be, we didn't ask the women about it, but what we are speculating is that it could be that after surgery, the women may need to take time out to manage the symptoms in terms of the treatment that they might have to undergo post-surgery. So that's what we're thinking that could be the reason. How do you track how many women having an hysterectomy due to endometriosis? This is, again, another really good question that we can try and address. First of all, what we can do is to look at the women's report of endometriosis, from when they were really young, like in their early 20s, and then we can see what happens to them in terms of whether they've had surgery for hysterectomy. And that's something that we will actively be looking towards analyzing the time, since diagnosis of endometriosis with hysterectomy. Now, a lot of time for these women, they'll have to wait until they finish their childbearing stage before they'll have a hysterectomy. But yeah, lots of really interesting work to be doing in this space. Okay. A question on, has there been research around for women who have endometriosis, also have thyroid disease? We haven't looked at that specifically, but one of the things what we are doing using ALSWH data is we are defining a list of conditions and diseases that women with endometriosis are more likely to also report. So I think this is going to be really, really interesting. So I'm hoping that so far with looking at women with endometriosis, what we found is that a lot of them do report problems with indigestions, for instance. So definitely looking women with endometriosis and all the other conditions, they're more likely to report. Okay, so is a determined prevalence based on surgical diagnosis or symptomatic diagnosis? It is based on both. Because the symptomatic diagnosis is only through self-report, but also that they've been prescribed the medication for endometriosis. So on whole, we are finding that the percent is about 11%, which is 1 in 9 women. But we do believe that this number is going to go up. The prevalence is going to go up as we get better at diagnosing the women. And if you just look at hospital, so of all the endometriosis cases that we looked at, there was about 1,600 in women in the 1973-78 cohort. We found that over 60% were actually diagnosed through hospital or MBS record, which is, I would say, quite accurate. How do you see your research findings informing current policy settings? Now, I think what the latest MRFF funding that we have is really trying to understand what are the risk factors for endometriosis. We're looking at symptoms a lot earlier in the women's life, so from adolescence onwards. We're trying to understand the role of genetics versus early life factors. So in order, what we're trying to do is really understand the etiology of the disease. If we understand it, then we can make informed choices, you know, and make those recommendations. One of the things that we're really excited about is hopefully we'll get our endometriosis risk calculator, which we are planning to trial it out and using different groups of women. And if we can, you know, get that prediction accurately, that would be fantastic. Are there any organizations or groups who are happy to give presentation or seminar on this topic in the community setting? The answer is there are loads of organizations. I can definitely talk about Quendo, which is based in Queensland, but there's also the Australia Endometriosis Society. There is heaps of them, which I'm happy to give you names if you get in touch with me. Yeah, has your research shown any link between inflammatory bowel disease? And this is really important question. We're working on it, but what I can say is that Professor Grant Montgomery's team have looked at the genetics of women with endometriosis, and there's a strong genetic association between endometriosis and the Crohn's disease genes. So I think this is an exciting, again, looking at the clustering of the conditions. So watch the space, but I'm happy to provide you with his contact detail. How much research has been done on manual lymphatic drainage as a treatment for endometriosis? I have to pass that question because I'm not aware. I don't know. That's the answer. In terms of cystic fibrosis and endometriosis, again, you know, what we're doing at UQ is, first of all, we're looking at all the genetic associations, and then we will tie in the genetics association with the women's reported conditions. So again, it is such an important field. Are there any particular demographics group of people that are likely to experience endometriosis? I think there is definitely an ethnic variation in the conditions. And I would say that I do know that Asian women are at a higher risk of endometriosis, but again, watch the space, we will be looking at it. And the same question with cystic fibrosis and endometriosis. I think we will look at endometriosis and all the conditions. What are the medications for people with endometriosis? I think the two common ones, definitely there's a hormonal treatment to it, and also depending on the conditions, they may also be recommended to take anti-inflammatory drugs. So those are the two common ones. The department does, provide funding to Pelvic Pain Foundation to undertake. Yeah, thank you. That's really helpful. Yeah. So I know there'll be more questions. It's a really exciting topic, but I'll let Katrina do her presentations. And if we have more time, we can discuss more at the end of the presentation. So thank you.
Hello, I'm Katrina Moss, and I'll be talking about fertility problems and help seeking, the use of assisted reproductive technology, or ART, and the implications of late diagnosed endometriosis on ART outcomes. Don't forget to post your questions during the talk and we'll answer them at the end. And I too would like to acknowledge the Turrbal and Yagara people as traditional custodians of the lands on which I'm sitting today and pay my respects to their ancestors and descendants. Yesterday you heard Annette talk about some preliminary findings from Major Report Q. Today I'm going to recap some of the findings from last year on fertility problems, help seeking and ART use. These provide a context for the new work we've done on endometriosis and ART. Major Report P focused on reproductive health. It covered contraception, fertility problems, ART, perinatal mental health, the menopause transition, and the impact of COVID-19 on family planning and contraception. We had several questions on these topics yesterday. If you'd like to read more about them, you can find the report on our website if you go to Outcomes, Reports, and then Major Reports. So this section focuses on the cohort born in 1989 to 95, who have done 6 surveys covering ages 18 to 29 years, and the cohort born in 1973 to 78, who have done 8 surveys covering ages 18 to 45 years. Looking at the 73 to 78 cohort, the percentage reporting fertility problems, which is the darkest band at the top, rose to 24.2% by age 40 to 45. Across all surveys, about 1 in 5 reported fertility problems. Help seeking increased with age. Around half reported seeking help in their early 20s, compared to around 80% in their early 40s. Of those who did seek help, just over half reported using IVF or fertility hormones, but a substantial percentage didn't report seeking any help. Comparing the two cohorts, the prevalence of fertility problems was similar at approximately the same age, so about 3.5% at age 22 to 27, and about 6% at age 24 to 30. So there's no real cohort difference in fertility problems. So far, we've been talking about self-report data from the surveys, but we've also got linked MBS data on ART for both the cohorts. This includes in vitro fertilization, or IVF, and intrauterine insemination, or IUI. We have almost 24,500 item numbers in our MBS dataset. These make up just over 7,000 cycles for about 1,500 women. This is almost $19 million in MBS benefits paid, with an average of just over $12,000 per woman, although this did range from $35 to $88,000. Women were out of pocket $11.5 million, with an average of $7,500 per woman, and this ranged from nothing to $59,000. Most of the cycles were IVF rather than IUI, and almost 20% of women used both treatments. These are the IVF and IUI cycles by age for the 73 to 78 cohort. You can see that IUI use, which is the light green, is consistently lower than IVF, which is the light purple. IUI use was highest at age 32 to 33 and declined from age 34. IVF use was highest at age 36 to 39 and declined from age 40. Results were similar in the 89 to 95 cohort. More women used IVF than IUI, and there is a decline for IVF at age 29 and 30 that we didn't see in the older cohort, but we're not making too much of that because our data go up to mid-2020, so it may reflect difficulty accessing services during COVID-19. Comparing the two cohorts at similar ages, the 89-95s, which is light green, started IVF earlier and were using it at slightly higher rates, even though there was no difference in self-reported fertility problems between the cohorts. So following on now from the major report, what we wanted to look at more closely was the outcomes of ART, and we were really interested in whether these were different for women with and without endometriosis. As you've heard from Gita, we established that 1 in 9 Australian women have endometriosis, and previous studies have found that about 40% of these women will have infertility. There are 3 main mechanisms for infertility in women with endo. The first is inflammation in the pelvic cavity, which alters interactions between sperm and egg and can impede natural conception. The second is that endometrial lesions on the ovaries and surgery to remove them can affect ovarian reserve and the response to ovarian stimulation, which can impede ART. The third is inflammation-related alterations in endometrial receptivity, which can impede implantation. The recommended treatment for endometriosis-related infertility is ART. Surgery isn't recommended because it can reduce ART outcome. Clinical guidelines in 2013 recommended IUI, and there are higher pregnancy rates compared to no treatment, but IUI doesn't bypass the inflammation in the pelvic cavity and might exacerbate endo symptoms or promote their recurrence. So IVF is now considered the treatment of choice. Previous studies haven't found any differences in live birth rates for women with endo and women with other causes of infertility, which seems like good news. But clinic-based research only has data from women during their fertility treatment. And retrospective recall of symptoms and diagnosis before treatment. And given that a diagnosis can take between 4 and 11 years, some women could have endo when they start fertility treatment, but not know that until afterwards. Clinic-based studies can't capture these cases. Longitudinal epi research, on the other hand, can capture symptoms, diagnosis, and fertility treatment regardless of when they occur. And I think you probably know where I'm going with this. Women in the 73 to 78 cohort had done 8 surveys so far, covering ages 18 to 45. And for most women, this is the majority of their reproductive lifespan. We used data from this cohort to investigate whether the use and outcomes of ART are different for women with and without endometriosis. We also wanted to know whether the timing of the diagnosis, that is, before or after they started their fertility treatment, made a difference. Diagnosis of endometriosis was based on 4 sources of information. These were self-reporting surveys, laparoscopic resection of endometriosis in linked MBS data, medications for endometriosis in linked PBS data, and a diagnosis of endometriosis in linked hospital separation data. Our ART information came from dates and item codes in linked MBS data. Outcomes included age at first ART, use of IUI and IVF, and number of cycles. We also looked at births after ART, and this came from self-report and linked perinatal data. And it's important to note that we were not able to reliably link individual births with ART cycles. So, results. Of the 13,508 women who consented to data linkage, 1,322 had done at least 1 ART cycle in Australia by 2020, which is 10%. Just over 1/3, which was 459 women, had endometriosis, but 34% of those were not diagnosed until after their first ART cycle. Early diagnosed women were about 5 years younger than late diagnosed women when they received their diagnosis. Early diagnosed women received their diagnosis about 2 years before their first ART, and late diagnosed women about 2 years after. And there were no differences between the 2 groups on any of the demographic characteristics we looked at. Like previous studies, we also found that outcomes were the same for women with and without endometriosis, but only for women who knew about their endo before they started their fertility treatment. Late diagnosed women were worse off on every outcome we measured. They were 2 times more likely to use IUI, 4 times more likely to do a lot of cycles, and 33% less likely to report a birth. And this was despite no difference in age at first ART. So we'll look now at each of these in a bit more detail. On the graphs, women without endo are the grey column, early diagnosed women are green, and late diagnosed women are purple. So looking at the use of ART, there's no difference by endometriosis status for women who only did IUI, and this is quite a small percentage of ART use. But you can see that more of the early diagnosed women only did IVF, and more of the late diagnosed women used both IUI and IVF. Of these, 89% did IUI before progressing to IVF, and that represents a delay in receiving the recommended treatment. In adjusted analyses, late diagnosed women were 2.1 times more likely to use IUI, either alone or in combination with IVF, than they were to use IVF only, compared to women without endo. Looking now at the number of cycles, we categorise these as 1 to 3, 4 to 10, and 11 to 36. There were no significant differences between early diagnosed women and those without endometriosis on the number of cycles. But late diagnosed women were overrepresented in these higher cycle categories, particularly 11 to 36 cycles. In adjusted analyses, late diagnosed women were 2.2 times more likely to do 4 to 10 cycles instead of 1 to 3 cycles, and 4.1 times more likely to do 11 to 36 cycles compared to women without endo. This might be partly due to doing IUI and then going to IVF. ART has a high financial, physical, and emotional cost. This high number of cycles represents a substantial burden to the health system and to individual patients. Looking now at whether women reported a birth after the date of their first ART cycle, you can see that overall, 10% fewer late diagnosed women reported a birth. The same was true when we broke it down by age at first ART. We've got under 35s on the left and 35 and over on the right. And again, you can see there's almost 10% difference. In adjusted analyses, late diagnosed women were 33% less likely to report a birth after starting fertility treatment. Overall, we found that late diagnosis of endometriosis conveys substantial disadvantage during fertility treatment. It also seems that using IUI might increase time to pregnancy. These are important findings and they should be a call to action. In acting though, we need to be careful not to veer into overdiagnosis. Diagnostic laparoscopies used to be conducted as part of the workup for ART, but it's no longer standard practice because it can reduce ART outcomes. And in our study, it would have resulted in unnecessary surgeries for hundreds of women. So without surgery, how do health professionals diagnose endometriosis? They can use clinical interviews, physical examination, and also imaging. Symptoms can also be a red flag for health professionals. We looked at endometriosis-related symptoms reported in the survey just before the first ART, which is on the left, and across all surveys before the first ART, which is on the right. Early diagnosed women had the highest prevalence of symptoms, which might be why they were diagnosed. While not quite as high, symptoms were still elevated in late diagnosed women, particularly severe period pain. This is the cardinal symptom of endometriosis, especially if it's cyclical. This work has been published in Human Reproduction if you'd like to read more about it. It also received great coverage in TV, print, and radio media. It's a hot topic, and it might be because at 1 in 9 women, either you are her or you know her. We have to catch these undiagnosed cases so we can improve outcomes across the board for women with endometriosis. You're welcome to post questions now or to contact Gita or myself later about anything we presented today. And of course, you can find more information on our website and socials. Finally, we'd like to thank the Department of Health for funding the study and the women who have provided this amazing data over such a long period of time. Thanks.
Hi everyone. So Gita and I are both here and we're happy to answer questions on any part of the presentation. So feel free to pop them in the, I think it's the Polev link, which you'll find in the chat. So we've got 2 questions in there at the moment. And the first is altered endometrial receptivity also impacted by accompanying conditions such as adenomyosis? And the answer is yes, it is. That's not part of our research, but that can also impact on embryo implantation. And those conditions can commonly co-occur. Second question is late diagnosis, does it refer to age or disease stage? In our study, we talked about late diagnosis as occurring after the women started fertility treatment. So ideally, people will know they have endo before they go into fertility treatment so that their treatment can be adjusted accordingly. So women who had that early diagnosis, which in our study meant they knew right from the start that they had endo and that they could make their decisions based on that information, whereas late diagnosed women started their fertility treatment not knowing that they had this underlying reproductive condition, which means that it couldn't be accounted for in their treatment. So that's how we classified early and late. That's just for our paper though. And in terms of why IUI is not as effective as IVF for women with endo, it's mainly because of all those inflammatory processes that are happening in the pelvic cavity get in the way of the interactions between the sperm and the egg, so they reduce the chance of fertilization. And also, if you haven't had surgery but you might have endometriosis, it's very possible that you've got endometrial lesions on your ovaries that are impacting on your ability to release an egg. So sometimes you might not even know that you're ovulating. So that's why IVF has a higher success rate for women with endometriosis, because it bypasses those processes because they happen partly outside of your body. Although some women do choose IUI first because IVF is scary and it's expensive. So, we understand that it's not just medical reasons why people might choose a different treatment option. So I guess what we would recommend for people who might be in this situation is have a good discussion with your specialist and with your GP. In particular, if you have pelvic pain or some of these other symptoms, they are important. Your pain does matter and you do deserve the treatment that's going to be right for you. So, I'd really love to see women being able to make informed decisions based on all the information at hand. How long does it take to be incorporated into our health system? I don't quite know. So obviously there's a lag between research and policy and practice, but certainly we've been really heartened by the recent policy developments and policy and funding focus on endometriosis, and we have high hopes that things are going to change for women. In particular, there's a lot more awareness in the community about endometriosis and how that manifests and what that means for people. Did you want to say any more about that?
No, I think you're absolutely right there, Katrina. I think the most important thing is that we are working very closely with the Department of Health. We're working closely with the group, the National Endometriosis Action Plan committees. So whatever results that we get that are robust and can be replicated in other studies, we'll be pushing for it to be incorporated into the health systems. Yeah.
Yeah, and we have had just a question in the chat to say, can someone get the PowerPoint? I'm happy for you to email me and I'm happy to supply the PowerPoint. So just get in touch with me directly. Yeah, we're really pleased with all the questions people have been asking. It's obviously a really important topic for people and we really appreciate your attention.
Yeah. Any other questions you have about 2 minutes or less than that. Yeah.
And my email address is
I think it's been posted.
katrina.moss@uq.edu.au.
I think Megan has already posted it in the chat. Oh.
So it's katrina.moss
All right.
at uq.edu.au.
Okay.
So yeah, get in touch if you'd like to.
So thank you so much, everyone, for listening to our presentations and also for all the really important questions. So
yes,
yes,
we would love to be there in person.
I know, definitely.
Yeah. It would be so lovely to see people's faces and have those great conversations. So we are really, really hoping that life might be a bit normal next year.
Yeah, instead of speaking to the computer screen, right? Yeah.
We miss you.
Yeah, so we will be in touch, guys. Thank you so much. Okay.